So good morning, everyone, and thank you so much for the invitation. I am thrilled to be joining you today to talk about antibiotic stewardship. And we're sorry we could not be with you in person, but I appreciate the opportunity to join you virtually. I have no financial relationships or any disclosures. And in the next 30 to 35 minutes, what I'll go over is some of the CDC's Office of Antibiotic Stewardship mission goals and the ongoing activities under these goals. You know, things we were able to continue over the last few years, but a lot of activities we're hoping to resume now that we have a little bit more time and bandwidth as you all are restarting your antibiotic stewardship work. We'll review some of the changes in antibiotic prescribing that occurred during the COVID pandemic nationally and identify some available and upcoming resources for antibiotic stewardship implementation. I think many of you are familiar with the slides. In 2019, the CDC updated the threats report that estimated that almost 2.9 million illnesses and over 35,000 deaths occur every year due to antibiotic-resistant infections. And presented it in this report separately as antibiotic use leading to over 200,000 cases of C. difficile and associated almost 13,000 deaths. And this was recently released that during the first year of the COVID-19 pandemic, there were more than 29,000 people died from antimicrobial resistance infections that are commonly associated with healthcare. And almost nearly 40% of those people got those infections in the hospital. And the reason I'm joining you today is that ensuring appropriate antibiotic use is one of CDC's 5 core strategies to combat the threat of antibiotic-resistant infections. So our office's main goal is optimizing and improving antibiotic use. And we categorize our activities under 4 main categories, which is leveraging antibiotic use data, and assessment of appropriateness of antibiotic use, assessing, supporting, and improving stewardship implementation, and enhancing knowledge both for the general public and supporting healthcare professionals in appropriate antibiotic use. So I'm going to structure this talk under these 4 buckets. So first, starting with AU data. And many of you are familiar and have worked with National Healthcare Safety Network data, or NHSN, which is the most widely used healthcare-associated infections tracking system and provides a mechanism for tracking AU data in hospitals. The antimicrobial use, or AU data option, is main objective is to facilitate risk-adjusted antimicrobial use benchmarking and help evaluate trends over time. However, our office also uses different administrative data to track and characterize the antibiotic use. And the number of hospitals that are submitting to their AU data to NHSN has steadily increased since 2016. As of July 1st, over 2,400 hospitals have reported at least 1 month of AU data. And on this map, you can see the percentage of facilities that are reporting AU data across the US, and those range from 9% per state to 69% per state. And you can see Nebraska is around 15%. So the standardized antimicrobial administration ratio, or what we refer to as SAR, is a summary measure of AU available to hospitals participating in the AU option. In the last 2 years, we have posted an NHSN data reports that provides those SAR distribution within an antimicrobial agent category in adult, pediatric, and neonatal patient care locations. This enables the hospital to compare its SAR to the national distribution and see where to improve. A new report will be posted in November. And I know many upcoming presentations are going to use these data, and some of you are familiar with it. But in an effort for us to make our data publicly available and to be used for action for antibiotic stewardship, several years ago, CDC created the Antibiotic Resistance and Patient Safety Portal. It is an interactive web-based application to display data that we collect through NHSN, through the Antibiotic Resistance Lab Network or ARLN, and other sources such as the Emerging Infections Program. It offers enhanced data visualizations on resistance, use, and stewardship data sets, and as well as HAIs. We are planning to post state-level SAR distributions that I just mentioned on the Patient Safety Portal later this year for US Antibiotic Awareness Week. If you do go right now to this link, there is sort of a beta version available where we're testing these data, but the formal version will be posted by November. So shifting to nursing homes, unlike other settings, we did not have a large data source available to characterize antibiotic use in long-term care. In the last few years, we have engaged with vendors, both from pharmacy and electronic health records, to characterize antibiotic use in these settings. And we've compared different data elements from these sources to learn more about the feasibility of automated reporting. Also, we continue the work of cross-sectional surveys that is led by our Emerging Infections Program, and their work was recently published in JAMA, characterizing antibiotic use on a single day in 161 nursing homes. And now shifting to outpatient settings. The Patient Safety Portal I just mentioned also displays outpatient data based on proprietary data from a company called Accubia. And however, similar to hospital, we use other proprietary and administrative data sources to characterize antibiotic use in outpatient settings and to identify opportunities for improvement. And these data, especially in outpatient setting, allow us to identify high prescribing settings. For example, you can see a snapshot from the map where we tend to see higher rates in the South, even after we adjust for several patient characteristics, and that helps us engage our state partners in improving prescribing practices. We also look by setting and by prescriber specialty. So, for example, we were able to identify higher rates of inappropriate prescribing in urgent care, and that led to engagement to urgent care professional societies and specific guidance around prescribing in urgent care. And also we've been tracking antibiotic prescription by specialty, and it comes at no surprise to anyone the growing role of nurse practitioners and physicians assistants, we can see in the green line, are contributing to a much larger percentage of antibiotic prescribing in outpatients. And it went from 2011 from 14% for NPs and PAs prescribing of total antibiotics to 32% in 2019. And this is leading to additional engagement with professional societies and adapting our stewardship material for different prescribers. Our team also recently published an MMWR highlighting the use of publicly available CMS Part D data to identify higher volume antibiotic prescribers for public health interventions. We also released an analytic guide on how these data can be used for peer comparison, audit, and feedback, and the links of both are on those slides. But in that MMWR, we highlighted that higher volume prescribers within these data, which are the top 10% by volume, write over 41 prescriptions of antibiotic prescriptions, highlighting that an engagement with these providers can potentially be high yield. So I'll pivot to talk a little bit about COVID-19 and antibiotic prescribing. Because our team has been working with these variable data sources across the spectrum of healthcare during the COVID-19 pandemic, we were able to quickly pivot and use these different data sources to characterize antibiotic prescribing in different healthcare settings. This work will continue so we can leverage the lessons learned. Overall, I'll talk a little bit about the different findings. There has been variability across settings with azithromycin prescribing, comes at no surprise to anyone here, was higher than expected in all settings. Hospital antibiotic use fluctuated and driven mostly by the use of azithromycin and ceftriaxone, shown here in the dark blue, and I'm not sure how it's projecting on your screen, but light orange or yellow. As COVID cases went up in March and April of 2020, and also in the winter, so did azithromycin and ceftriaxone. This is more clearly seen here in nursing homes, where you also found those peaks of azithromycin and ceftriaxone prescribing. The percentages labeled at the peaks indicate increases month over month when you compare 2020 to 2019. And pivoting now to the outpatient setting, there was a sharp decline in overall antibiotic use and changes with healthcare delivery and prioritization of inpatient services. Represented here, you see outpatient prescription initially decreased in 2020, and then represented by the gray line, but then it rebounded in 2021, and if you see the orange line. This reflects, as I said, several factors and changes in healthcare utilization, the decreases in transmission of respiratory infections early in the pandemic with mask wearing and social distancing. However, in August 2021, antibiotic use exceeded that of 2019, and it increased compared to pre-pandemic levels. And similarly to inpatient to nursing home, after an initial peak at outpatient azithromycin prescribing, it decreased during the pandemic. However, most of the increases in outpatient setting were due to azithromycin. So these data that I just presented describe overall antibiotic use and not specific to COVID. We did look at patients specifically diagnosed with COVID and prescribing practices to them, both in hospital and outpatient. And this manuscript described an aggregate antibiotic use rate for hospital from COVID discharges specifically with Premier data. Most patients hospitalized with COVID received an antibiotic, 77.3%. And over 80% of those were started on admission. And almost half received ceftriaxone, most commonly in combination with azithromycin. And when we looked also at outpatient older adults who were not hospitalized, were diagnosed with COVID, the numbers did fluctuate and did vary somewhat by setting, but overall, around 30% of those patients did receive an antibiotic, most commonly azithromycin. Early on in the pandemic, there was a lot of uncertainty, but there is significant literature that's been published since then on the incidence of secondary bacterial infection with COVID-19, especially on hospital presentation. Co-infection overall was found in 3.5% of hospitalized patients in one meta-analysis. However, those were uncommon at presentation at 1.2%. However, as we just spoke in the COVID report that CDC recently released, high illness acuity, longer length of stay in hospitalized patients led to the development of HAIs and the spread of resistant pathogens. In a retrospective cohort, 7% had a proven or possible infection 48 hours after admission, and risk factors for those other than ICU admission and steroid use and severe disease was also antibiotic exposure on admission. So there's been many lessons learned from the pandemic. On one hand, the pandemic highlighted the importance of stewardship skills, who were called upon to help support treatment of patients with COVID-19, create guidelines on the fly, and adjust for drug shortages. Many stewards were able to pivot to provide this type of support. COVID-19 diagnostics were crucial for the management. So the skills on diagnostic stewardship that the antibiotic steward have were particularly useful, especially early on when testing supplies were limited. But we also learned that poor quality studies and desperation to find solutions and media attention led to rampant antibiotic use. And there were some program had limited resilience in terms of being able to sustain their stewardship roles. We also are now increasingly engaged with telehealth services, where the role of telehealth has become much more important than before, quickly during the pandemic. And although some of that is going back to normal now, but there's a continued increasing role of telehealth and care. And this provides both challenges and opportunities for antibiotic stewardship. And we're actively engaged with telehealth providers in integrating antibiotic stewardship into their platforms. So with that, I will move to talk briefly about the assessment of appropriateness of antibiotic use. I talked about overall use, but we are looking closely at appropriateness, mostly in hospitals, with CDC's Emerging Infections Program that highlighted opportunities where antibiotic could be improved for community-acquired pneumonia, urinary tract infection, prescribing of specific agents. And there's a planned follow-up for this work in 2023. In outpatient setting, we have focused on characterizing the appropriateness of acute respiratory infections and funded the development of a new NCQA HEDIS measure that was released this 2022, and are working with multiple partners on appropriateness of prescribing by healthcare setting and by specialty. So we've talked about antibiotic use and to identify opportunities for improvement, and that guides both our work in communication and education. However, the CDC is actively engaged in assessing, supporting, and improving antibiotic stewardship implementation. I don't think anyone in this audience needs an introduction to what the core elements are. But just as a quick refresher of how long we've come, the Hospital Core Elements for Antibiotic Stewardship Framework was released in 2014, an update in 2019. And those outline the structural and procedural component associated with a successful stewardship program and focus on leadership, accountability, having available expertise, actions, tracking, reporting, and education. And the core elements, when they were created, they were intended to be an adaptable framework that other healthcare settings can adapt. And this is exactly what we did with engaging professional societies and providers and partners. Those documents were adapted to nursing homes, outpatient, small critical access hospital, and resource-limited settings, and take into account those unique challenges and resources in different settings. When we are engaging with different specific settings, such as dialysis, although outpatient dialysis settings are technically fall under the outpatient core element, but this is a very unique population. So we worked with the American Society of Nephrology and other partners, and recently published a paper on opportunities and strategies to improve antibiotic prescribing in dialysis setting. So all of these documents provide a framework or a guidance, but they are not regulatory documents. But CDC's core elements do play an important role in regulatory and accreditation stewardship standards. For hospitals, in 2019, CMS published a final rule requiring hospitals to have an antibiotic stewardship program. And earlier last month, their interpretive guidance was published. And the Joint Commission accreditation standards that were started in 2017, the new and revised stewardship requirements will apply to all Joint Commission accredited hospitals and critical access hospitals in January of 2023. And similarly, in hospitals, the core elements play an important role in the interpretive guidance for the CMS requirements for nursing homes of having an antibiotic stewardship program within their pharmacy and infection prevention and control program. So we use that framework not only to guide implementation and provide that framework, but for us to assess how stewardship is being implemented, track progress, and identify gaps. And I shared with you some screenshots of the patient safety portal, and also on the patient safety portal, we post antibiotic stewardship data. And these are based on what facilities report to us when they report to NHSN and fill an annual survey. And with this ongoing engagement, you can see with the increasing bar charts that over 90% of hospitals are now implementing all 7 core elements of antibiotic stewardship. So with that progress, we established priority criteria for the implementation of hospital core elements. For example, we emphasize prospective audit and feedback, pre-authorization, and facility-specific treatment guidelines as priority implementation actions. And these criteria will be incorporated formally in the patient safety portal by the fall of 2022. And similar to hospitals, nursing homes also reported implementation of the core elements. And since we started looking at this from 2016 to 2018, there's been a steady increase of reported core elements implementation. And we plan to incorporate the data in the patient safety portal tool later this year. However, we do look at other data sources for assessing core element implementation. With CMS requiring stewardship, we have done a qualitative review of CMS stewardship citations that were issued during nursing home facility inspections and categorized those under the core elements to identify gaps and where support is needed. And we will present more on this analysis later in the afternoon during the long-term care track. In outpatient setting, we are engaging with healthcare payers to support stewardship implementation and developed a toolkit for healthcare payers to improve prescribing. We are also funding partners and professional organizations for stewardship interventions in high priority settings. You all know about the growing role for antibiotic stewardship, and the more money that has been made available to help with infection prevention as a result of COVID-19. You may have heard that CDC is investing $2.1 billion through the American Rescue Plan over the next 5 years to enhance infection prevention control and antibiotic stewardship activities. And as part of improving stewardship, health equity and antibiotic prescribing is also a priority for us. So we are exploring our existing data sources and characterizing the literature on inequities in antibiotic prescribing to inform our research priorities and intervention. But the main focus for us, since around $120 million of this American Rescue Plan is dedicated to stewardship, is providing access to stewardship expertise at the health department level to support stewardship implementation across different healthcare settings. So last, I will go over education, and which is enhancing healthcare professional and general public knowledge of appropriate antibiotic use, and present just a few examples of resources and materials that are posted on our website. We have recently updated the CDC antibiotic use website and updated our resources and removed older material that are not very relevant, and categorized our implementation resources for the core elements by setting. And those implementation resources are the most dynamic part of our website, where we are constantly posting new material that are being either developed by us, by our professional partners, or by health departments. A few years ago, we released the 5 ways hospital pharmacists can be antibiotics aware resources, which are several documents that present opportunities for improving antibiotic use when led by pharmacists. Those materials have been adapted to nursing homes, and those have been posted. And there are community pharmacy materials that are coming soon, and we plan to do promotion for the entire package of pharmacy-specific material together. We developed resources for healthcare professionals to optimize treatment and communication at hospital discharge, including highlighting key prescribing elements that should be communicated across transitions, especially when patients are discharged to nursing homes. We are also adapting communication material from the outpatient setting to nursing homes to optimize communication with residents and families, and highlighting the communication principles of reviewing findings, delivering clear diagnoses, how to best provide treatment recommendations, and making sure that a communication contingency plan is communicated, and adapted those to nursing home specific scenarios, focusing on asymptomatic bacteriuria and respiratory infections. And diagnostic stewardship is an important priority for our office, and diagnostic stewardship has been highlighted in the core elements with guidance documents on how to best engage the microbiology lab in the hospital. This is a recently posted material on blood culture contamination, and there will be more coming. Some of you may be familiar with the CDC training course on antibiotic stewardship that provides over 10 hours of free CE credits for providers. And it has over 10 modules on antibiotic resistance, benefits of stewardship, and reviews stewardship principles across the spectrum of healthcare and considerations for management of outpatient conditions. The course is currently being updated. Around half of it now, the content has been updated and renewed, and the rest should be completed before the end of the year, with newer content that is going to be specific to urgent care settings and other settings will be posted over the coming year too. And many of you are actively engaged with this, especially our health department partners. US Antibiotic Awareness Week is our annual observance to raise awareness about the threat of resistance and the importance of appropriate antibiotic use. During the week, we engage with partners with activities and events that promote appropriate antibiotic use. And we do release many of our new material and highlight some of our new resources during that time. And with that, I am happy to take questions, and my contact information is at the bottom of the slide. If anyone wants to engage with us or ask us questions later, we are also happy to do that.